Thank you for attending the Borneo Urology Update 2021. My name is Meng. My task today is to talk about the natural history of prostate cancer, in particular about biochemical recurrence and how to manage biochemical recurrence. The aim of my talk is to tell the audience what happens if prostate cancer progresses after curative treatment. Do we need to treat this condition? And what tools are available to prognosticate? And how do we manage biochemical recurrence? By definition, biochemical recurrence depends on the type of initial curative treatment. In radical prostatectomy, it is defined as 2 consecutive rise of PSA above 0.2 nanogram per deciliter. However, this value has been found to be more accurate to predict metastasis or progression. It is taken at PSA of above 0.1. For radiotherapy, based on the Phoenix criteria, biochemical recurrence is defined as PSA 2 above the nadir PSA during treatment. So what is the natural history of biochemical recurrence after curative treatment? We know that from large-scale studies that 30% of prostatectomy patients and 25% of radiotherapy patients progress to biochemical recurrence. And based on a few studies, within 10 years of treatment, 20 to 40% of radical prostatectomy patients progress to biochemical recurrence, whereas about 30 to 50% of radiotherapy patients progress to biochemical recurrence. And once biochemical recurrence has occurred, the patient is said to have recurrent prostate cancer. And it is important to remember that these patients are asymptomatic of any local or metastatic disease during diagnosis at this stage. And there is no immediate impact on the quality of life for this patient. And the biggest impact on the quality of life is physicians telling them that they have recurrent prostate cancer, hence inducing anxiety in these patients. Let me go through this slide. This is a slide of the current treatment landscape of prostate cancer. On the horizontal axis is time, on the vertical axis is tumor burden activity. The red line in the middle indicates the current state of disease for the patient. Biochemical recurrence is the first turning point in the patient's journey in this disease. And why is it important to know this state of disease? It is important because a rising PSA usually precedes metastasis in about 8 years following radical prostatectomy and 7 years following radical radiotherapy. And the progression from metastasis death is approximately 5 years. However, biochemical recurrence has a very prolonged history, and it has been shown to be an independent risk factor for disease mortality, prostate cancer specific mortality, and overall mortality. Nevertheless, the management is rather controversial because the impact of biochemical recurrence on each individual patient is different. Not all have the same prognosis, and it appears that only a subgroup will progress. Hence, in managing biochemical recurrence, it is very important to stratify the risk of the patient in terms of the patient's risk of progression and patient's risk of metastasis. It is important to prevent or delay the onset of metastasis disease and also minimize treatment-related morbidity. And as treating physicians, we have to be aware that there is a real negative impact on the patient's quality of life. And it's important to avoid over-treating cancer that has low risk of progression or may not even affect patients' overall survival. So what prognostic tools do we have to manage biochemical recurrence? From large-scale meta-analysis, we know that there are 3 important clinical factors. Firstly is the initial tumor grade detection, meaning Gleason score. Second is the PSA doubling time. The PSA doubling time is usually calculated using an online calculator, using PSA value at certain time. Also important is an interval to biochemical value, indicated here as IBF. This meta-analysis validated on European group of patients. Using these three clinical factors, we can classify patients into a low-risk biochemical recurrence group and a high-risk biochemical recurrence. For low-risk biochemical recurrence, PSA-DT is usually more than clear, ISUP is usually less than 4, and IBF is more than 18 weeks. In the high-risk biochemical recurrence group, PSA-DT is less than a year, ISUP is 4 or above, and IBF is less than 8 months. This applies to both radiotherapy and radical prostatectomy. Clinical T-stage and pathological T-stage is also significant in this meta-analysis, but is not included. And interestingly, surgical margins and lymph node status were found not to be significant factors to classify this group of patients. Using these three clinical factors as a moderate predictive ability with a C index of just below 0.7. Following the diagnosis of biochemical recurrence, we usually have to stage the patient. And usually the first is some form of imaging. It has to be noted here that standard imaging modalities rarely detect metastasis in asymptomatic patients at this stage. For example, the usual bone scan can only detect less than 5% of patients with a PSA is less than 7. And CT scan has very low sensitivity in the range of 11 to 14% for local recurrences or any lymph node metastasis after radical prostatectomy. So at this stage of the disease, standard imaging modalities are usually not helpful. Because in order to change the disease course, the aim of early imaging is to detect localized recurrent prostate cancer amenable to salvage radiotherapy or other local therapy. And for salvage radiotherapy, the PSA has to be less than 0.5 to make any significant change in the course of the disease. As standard modality imaging is not very useful at this stage, we depend on next generation imaging. What do we mean by next generation imaging? Here we use multi-parametric MRI and PET scan. For multi-parametric MRI, the diffusion weighted imaging and dynamic contrast enhancement sequence are the most important. To detect bone metastases, the short tau inversion recovery sequence plus the DCE P1 sequence are used. However, this is of limited availability because not many MRI can do whole body MRI, and it is limited by the software availability. For multi-parametric MRI, there is a 90% sensitivity of detecting metastases with a PSA of 0.59. For PET scan, the current interest is in the use of PSMA PET or prostate-specific membrane antigen PET scan, due to its ability to detect metastases at very low level of PSA as indicated by the slide. The standard FDG PET is inappropriate to be used in biochemical recurrence as it's not sensitive. So what are the staging for biochemical recurrence? Patients who are at low risk of having biochemical recurrence or are classified as low risk biochemical recurrence group may not need to be staged, and just routine PSA observation is adequate. However, following radical prostatectomy, PSMA PET is very useful to exclude metastatic disease when the patient has entered biochemical recurrence. For post-radiotherapy, NDMRI is very useful to detect local recurrence. And more importantly, a repeat biopsy of the prostate is important to document proof of local recurrence. PSMA PET can also be used at this stage. However, it lacks high resolution compared to NDMRI. So what are the treatment options available for recurrent prostate cancer? PSA-only observation is a reasonable option, especially for patients in the low-risk biochemical recurrence group who may not benefit from salvage. However, this option may be viable even for high-risk biochemical recurrence patient group. In a recent publication from Johns Hopkins as well as Walter Reed Hospital, it was found that patients who preferred androgen deprivation therapy until metastasis have quite long median overall survival as well as median metastatic free survival. Having said that, it was noted that PSA doubling time of less than 6 months is associated with higher risk of metastasis than PSA of less than 10 months. At higher risk of mortality also are patients in the older age group, as well as patients with high pathological T stage, high Gleason sum, and a very fast PSA doubling time. Following prostatectomy, if the patient is in the high-risk biochemical recurrence group, salvage radiotherapy can be offered if the PSMA PET shows that the disease has not metastasized and is confined to the prostate. It's been shown that this patient responds very well to salvage radiotherapy, with 83% of the patients having a treatment response and maybe curative. And the usual regime is usually 66 grays to the prostatic fossa. And patients usually have 80% chance of having progression-free in 5 years. And in some studies, patients with PSA-80 of less than 6 months are shown to have some survival benefit using salvage radiotherapy. So how about addition of androgen deprivation therapy, ADT, to salvage radiotherapy? This is usually used in patients in the high-risk biochemical recurrence group with aggressive clinical features such as a pre-salvage radiotherapy PSA more than 0.5, patients who are surgical margin positive, or patients who have isograde of 4 above. What we know now from a few recent published trials is that there is no role for adjuvant radiotherapy, meaning following radical prostatectomy, if the patient has high-risk aggressive clinical features but has not reached biochemical recurrence, we should not subject patients to radiotherapy. How about primary use of androgen deprivation therapy in this group of patients? At the current stage, there is no level 1 evidence of survival benefits in using primary ADT in biochemical recurrent patients. As shown by Catherine Marshall study, the median overall survival and median metastatic free survival is quite prolonged with deferred androgen deprivation therapy. Even if one is to use ADT at this stage, it is uncertain whether it should be used immediately or delayed, how long to use it, and whether we should use ADT as a continuous form or in an intermittent fashion. The problem with using ADT at this stage is that we risk creating a new disease stage, the new disease step that is called non-metastatic castrate-resistant prostate cancer. As found by the previous study, Patients who have non-metastatic castrate-resistant prostate cancer are all from the group of patients who were given ADT at the start, whereas patients who preferred ADT are still hormone sensitive when they develop metastatic disease. How about patients who chose to have radical radiotherapy as a curative treatment? Again, there is a lack of quality data to guide us how to treat these patients. Local salvage therapy can be offered for patients who have low comorbidity, who have life expectancy of more than 10 years, who have PSA and BCR of less than 10, or with low ISO or low stage, and who show no lymph node in their imaging. This is because local salvage therapy can affect patients' quality of life. For example, following curative radiotherapy, if we subject patient to salvage radical prostatectomy, there's a 30% risk of anastomotic stricture. There's also a 2% risk of rectal injury, and the patients will have erectile dysfunction and has an increased risk of urinary incontinence. Other local salvage therapy have also been used. These include salvage cryotherapy, salvage HIFU, which is high intensity focused ultrasound, and also salvage brachytherapy. However, locally, I must say that we have very limited experience with this. However, what is known is that, again, one should not offer androgen deprivation therapy to non-metastatic patients, especially those who have PSADT of more than 12 months, because they will not benefit. And we risk creating a new disease state called non-metastatic castrate-resistant prostate cancer. So what is the take-home message for my presentation? I would like the audience to appreciate that recurrent prostate cancer following curative treatment usually has a prolonged course, and that clinical factors and next-generation imaging will be important in stratifying these patients into low-risk and high-risk groups. And timing of treatment will need to be individualized for this group of patients based on best available evidence in order to maximize overall survival, maximize metastatic-free survival, while preserving quality of life. Thank you very much for your attention.